Welcome to Breakthrough. Today we're going to be talking about using the new Arthrex Synergy MSK ultrasound for imaging. We have with us in the studio Dr. Kevin Kruse from Dallas, Texas, Dr. Brian Cole from Chicago, Illinois, and Dr. Alan Hirahara from Sacramento, California. Gentlemen, thank you for joining us today.
Thank you.
So let's start with you, Alan. How did you initially get started with ultrasound?
It was interesting. I actually was in a conference in 2009 in Europe. I started realizing that the Europeans and Asians were actually far ahead of us, and they were using ultrasound as a modality in many different areas. And so I came back and really got into understanding more about it and really realized it could really change the way I did medicine. It helped treat my patients so much better, not just from therapeutic injections, but also our diagnostic abilities in the clinic, on the sidelines, and eventually I started using it in the operating room.
Thanks, Alan. Brian, what about your introduction to ultrasound? Was it similar?
Yeah, similarly, we were looking at all the research that was being done in Europe and how they were able to do outcome studies with ultrasound, and we were still using MRI, which was incredibly inefficient. It was not really practical, and we wanted to learn ultrasound initially just to be able to do follow-up studies after arthroscopic rotator cuff repairs. And that kind of naturally evolved to using ultrasound when we would use therapeutics at the time of treating various conditions like osteoarthritis to make sure when we're using a therapeutic, we're actually getting it in the proper place.
Now, Kevin, you've had a little bit different pathway during your training. Maybe you could elaborate on your experiences with ultrasound.
Absolutely, Chris. So I actually started doing ultrasound in my residency in the United States early on, but I did a shoulder fellowship in France. And in France, they have a unique healthcare system, not like ours, where everybody that has surgery gets admitted the night before. So on the shoulder service, we would sometimes have 15, 16 people there getting rotator cuff repairs the next day by the shoulder surgeons we were working with. And we had to go around every night and do constant scores. Some of the fellows that I was working with, they wanted me to teach them how to do ultrasound because I had some experience with it. And so we ultrasounded all these patients knowing they had cuff tears. And then the next day we would look at the images that we had saved and we would correlate what we were seeing on arthroscopy. They were shocked because after 2 to 3 weeks of doing this, they were able to call not only that they had a full thickness tear, but the location, the size of the tear, the patterns of the tear, in really impressive detail. By the end of that experience, they had both made the decision that it was going to be a huge part of their practice, and I had made the decision that it really was going to supplant MRI for the vast majority of my shoulder imaging for rotator cuffs.
Alan, how is ultrasound currently used in your office in surgical practice?
So in the office, we use it for pretty much every therapeutic injection we do. We, of course, use it for diagnostic purposes as well to check not just preoperative patients and evaluation on first intakes, but also post-op patients. We're able to see the patients in post-op and make sure that if there's any problems, we can verify that the repairs look good or if there's any other issues with the surgery. And then in surgery itself, we've been actually be able to really innovatively use the ultrasound for different techniques, as in biceps tenodesis, ALL reconstruction, MPFL repairs. We've actually done several studies and techniques that have really innovated how we do things.
Wow, so it's really an integral part of your practice. Now, Brian, what is the workflow like in your office? Do you use ultrasound exams or does your PA perform them as well?
So our current integration is basically we have 2 machines that we use. We purposely use it for diagnostic issues when we're trying to improve the patient experience in terms of getting immediate results and information. Typically, when we're having a rotator cuff patient, we're trying to make treatment decisions based on that. That's where we likely use it the most, as well as for potential elbow ligament injuries and so forth. And most importantly, I think we're using it for therapeutic injections. Specifically, we've had some early work that was published looking at the specificity and sensitivity of our ability to inject, even though we all think we're great at doing this. As many people know, our accuracy is actually not as good as we think. And because of those results, what we now do is for virtually every glenohumeral injection, every AC joint injection, and every biceps injection, rather than just using anatomic landmarks, we use it to make sure we're truly getting to the right place. It improves the patient experience dramatically. So I've been fascinated by how we actually think we're in one place, and then when you use the ultrasound to show us, we find we're in a different place. For example, in a chronic case of patellar tendonitis where we were using the ultrasound machine and I said, look, let me just push on it, make sure I'm there, put the needle in, and thinking there's no way I could possibly be outside the tendon, the needle tip was below the tendon. And I was only in maybe a 1/4 of an inch for the length of the needle. So pulling it back, changing my angle made all the difference. And I clearly would have been outside the tendon with sometimes what might be a very expensive therapeutic.
So you think there's a subset of patients out there who failed a particular treatment, some type of therapeutic modality, but in reality, they didn't get the therapeutic medicine in the right place?
I think that's absolutely true. I mean, we've actually looked at those studies, and you can see at least 30% of injections being inaccurate. And that's with experts, fellowship-trained surgeons being in the wrong spot. And that's even dropped as low as up to 40% of accuracy, like with biceps tendon. Even with a simple knee injection, which we all think we're really good at, Unfortunately, sometimes, especially in the suprapatellar pouch, there's no effusion, and your space to hit has to be less than 1 millimeter. So you have to hit a spot that's only 1 millimeter thick at best. So I absolutely think that these therapeutic injections are necessary to be done under ultrasound, in fact.
So Kevin, how have your patients responded to ultrasound, and how do you decide between getting an ultrasound or getting an MRI?
So I would say across the board, they have loved it. I think when you compare ultrasound versus MRI for imaging purposes, ultrasound wins on many levels, the most important being cost. An ultrasound is on average about 1/10 to 1/15 the cost of an MRI. It's also much more efficient, so they don't have to get pre-approved, they don't have to go to the MRI and then come back and either talk to you on the phone or see you for another appointment for the results. You can get your diagnosis right then and there, and the patients absolutely love that. I think that they enjoy the interaction of being able to look at the screen and see their pathology as you're showing them their anatomy. And I have a couple videos on my websites, and by far, out of all the videos that I've done talking about different things with shoulders, I get the most comments on the ultrasound. And I've had many patients tell me that they came to see me specifically because I do this. So every new patient that comes in to see me with shoulder pain that I have a suspicion that they may or may not have a rotator cuff tear gets an ultrasound exam in my office. I look at it like an x-ray. I mean, most of us get x-rays when patients have pain. We don't think twice about it from a cost or efficiency standpoint.
But I think it goes beyond that. If you have ultrasound, you can actually image different types of anatomy that are not necessarily planar. So for example, MRI is all about planes, axial plane, sagittal plane, coronal plane. But there's a lot of anatomy that's not necessarily planar, like the ALL. And that's actually something that we cannot really see except more than 60% sensitivity on MRI. Whereas on ultrasound, it's almost 100%.
I agree. And also assessing things dynamically. For instance, a biceps tendon that subluxed out of the groove. I've seen 3 of those in practice where someone actually had an injury and they subluxed their biceps tendon out of the groove. You can see it with you internal rotation, external rotation of their arm, and it's an injury that I can't imagine another modality being able to see it other than ultrasound.
Yeah, and I think what you're alluding to is the fact that you have the ability to do something dynamically where, generally speaking, we don't have that ability with MRI. You can do it, but that's not a protocol. So the fact that you can actually ask the patient, is this reproducing your symptom? Is this analogous to what you're feeling? And then do something provocative and show it in a very anatomic way is something, there's nothing we really can compare that to other than potentially doing it arthroscopically.
I think that's 100%. We can actually dynamically check the UCL, we can dynamically check the MCL, the anterior tibial-fibular ligaments. We can stress them and see them opening up or not opening up under ultrasound directly.
Along those lines, Brian, how has ultrasound affected your use of other imaging modalities?
Well, it's changed my decision making. So for example, if I have a patient and I may have a high suspicion for a cuff tear, it could be just by history, insidious versus traumatic onset. Essentially my algorithm is most of those patients, when they have a chronic setting where they have an acute on chronic aggravation, they're going to get non-surgical treatment, but I get initial information out of the box. May not change my decision for surgery, but it gives them a plethora of information that they otherwise don't have. Let's face it, many patients come to the office expecting an MRI, and giving them this type of information, showing them how they can obviate the need to get that from an inconvenience and discomfort point of view is huge.
So Kevin, what procedures or diagnoses has ultrasound had the most profound impact in your practice?
I think far and away rotator cuff wins out for me as being the most common diagnosis that I get with ultrasound. But other uses that I use it for, guided injections in the shoulder, as Brian alluded to earlier, acromioclavicular joint, glenohumeral joint, even the subacromial space. People assume that all you have to do, or surgeons assume all you have to do is get underneath the acromion to get into the subacromial space. Well, the subacromial space in a lot of patients is a very small area on the very anterior aspect of the acromion, and it's a potential space. It's not a real joint per se. And so when you look at this and you see it under ultrasound, how small that area is to get into, you surprise yourself to think, wow, I wasn't getting where I needed to be very often. And also biceps, another area, since I do a lot of upper extremity work too, is nerve blocks in the upper extremity. So doing a nerve block of a radial nerve for radial tunnel, that's very difficult to do blind to get the medicine close. And I think guided injections throughout the upper extremity it's a phenomenal tool.
We've had the experience actually in also managing our athletes. We're fortunate to be able to have a machine we cover baseball, we cover basketball. Having that in the training room has made a huge difference because many times these are soft tissue injuries and we have to make a split decision that we feel comfortable with, that the patient's going to be safe, the athlete's going to be safe. Also provides reassurance to the athlete. So to be able to do things like say, hey, look, you don't have a stentor lesion or you don't have a complete disruption, it's a low-grade strain, you can see that the fibers are intact, makes a huge difference in terms of giving the athlete the reassurance that it's very, very safe to go back to sport. And then the other issue, as you say, it's sort of about patient flow and providing a quality experience for the patient, which they want to have a good experience, and that's something they can't necessarily get anywhere else. Giving them an accurate diagnosis right away, even if it doesn't necessarily change their decision making, giving them information that they otherwise can't get immediately or efficiently or economically, I think is a huge advance. And as we get better at this, I think it just becomes it's like doing the history physical, and then we have this anatomic diagnosis.
Absolutely. And I know you talked about how, when you initially started doing it was for research purposes with rotator cuffs, the expense to do MRIs for rotator cuffs at 2 weeks, 6 weeks, I mean, it's impossible. I mean, it is really nice if someone comes in, they've had a rotator cuff repair, they're 6 weeks out, they're still having some discomfort of 3 months, to show them that their repair is healed. It gives these patients confidence that everything's okay, and I really think it lifts the psychological burden from it and it improves their outcome.
The biggest thing that patients have is they have concern. So they come in and they think they've done something wrong or they're not progressing properly and something must be wrong. And they can do something totally innocuous and they think they may have done something. And the fact that, if you can actually pull the probe and say, look, your tendon is intact, you can see it moving, everything is fine, you're gonna be fine. They walk into the office and that's priceless. That's way better than an MRI or any diagnostic procedure can provide to them.
I totally agree. In fact, I've even brought this out on the sidelines. So when I have to cover games, and so we're able to have that person on the sideline be assessed. We can tell if there's a fracture. We can tell if there's a sprain or actually a hematoma or a complete rupture of something. So we don't have to run them back to the training room to get an x-ray or an MRI. We can actually have a immediate evaluation, and they can be back in the next play confidently without being in danger. And then post-operatively, I totally agree. We're able to assess these things. With the advent of superior capsule reconstruction, one of the big questions is integration of the graft. One thing that we've been able to show with ultrasound, which you can't do with anything else, is pulsatile vessels, which we've shown very clearly in the 4 to 8 month mark after implantation of these grafts. We can actually see the actual vessels inside the graft pulsating with blood, which obviously is going to indicate integration, which is interesting because with no other modality could you do that immediately.
Yeah, it's amazing.
And I would add 2 more patient populations that benefit from ultrasound. One would be those patients who have a pacemaker or some contraindication for an MRI. So I think that's very helpful. And then the other one is that patient who's claustrophobic. And I seem to see a lot of those in my practice, I can tell you that much.
Absolutely.
Yeah, I would rather have this than an open MRI. So to get an inferior MRI to accommodate the patient and also have to give them Valium or some other sedative to be able to tolerate, this is far more acceptable from the patient's perspective.
So along those lines, Brian, from a therapeutic standpoint, studies have been published on the benefit of using ultrasound for needle guidance. Do you believe your ultrasound-guided injections are better when compared to your traditional techniques?
Our first interest in that area was actually looking at this from a methodologic point of view and saying, hey, what's out there in the literature? And essentially, we published this a couple of years ago in AGSM, and it looked at our specificity and reliability and actually getting it in various joints. And it's a humbling experience to learn that we're not doing as well as we think. And I think that's the first thing is you sort of have to set your ego down and say, look, despite the fact that I'm here frequently arthroscopically, there's lots of ways to miss, lots of ways to get it wrong, and there's lots of ways to assume that you're trying to help a patient and have helped the patient when we have, in fact, not done that when doing it blindly. So especially for biceps sheath injections, the fact that you get immediate visual feedback, you see the sheath fill up, it's incredibly gratifying. The patient sees it. The AC joint can be particularly tricky, even though you think you're always there. You may just be on top of it, not actually in the joint. So just because they get numb doesn't mean we've actually delivered therapeutic benefit into the joint. And same thing for the glenohumeral joint. And I would agree that the subacromial space, I think it's much like the knee. We're misled to believing that we're always there. Just think about what happens when you put a camera in the back of the shoulder in the subacromial space. It's really a potential space and can be compartmentalized. So think about when you're trying to get your spinal needle in from the side, sometimes you can barely find it because it's buried in bursa and other tissue. That same thing could be happening at the time of an injection. So I think if we're spending the time to make a treatment recommendation, we're going to engage and deliver that treatment, we should probably spend the same amount of time and energy to make sure the treatment's getting to where it belongs.
Yeah, in fact, I've even talked to surgeons all the time as we give these courses, and I first show them the suprapatellar pouch, which sometimes have no effusion and is only the potential space of 1 millimeter. You mentioned the subacromial space, same thing. And it's a very simple question. I ask these surgeons, okay, if you're so good and you never miss, then tell me, when you do an actual intra-articular injection, be it a shoulder or a knee, does your patient ever have pain? And to a person, they'll say, well, sure, it hurts occasionally. Well, I'll tell them flat out, it shouldn't. Because if you're going into a space, into a joint, there is no nerve ending. It should not hurt at all. So that means if you add any kind of pain from these injections, you're either in the capsule, the fat pad, or you're in the muscle, you're in the tendon, you're in the ligament, you're somewhere else, but you're not in the joint.
So Alan, if ultrasound is more efficient and of great value from both a diagnostic and therapeutic standpoint, what are the biggest reasons from healthcare professionals why they don't use more ultrasound?
I think at this point it's simply just a matter of not being educated. It's not being taught much in residencies or fellowships, at least for orthopedic surgery. It's something that we're not really used to using. It's not a modality that we're comfortable with, and it's something that we just need to be educated about. As more and more of these courses are being taught, I'm finding more and more orthopedic surgeons are showing up and understanding the utility. And at this point, we're now also starting to see publications showing ultrasound-guided injections, ultrasound-guided surgery as being more effective and better for our patients. And then the breakthrough now is, of course, the advent of this new technology, which makes things mobile, more useful. We now can take this in the OR without the use of cords that could potentially cause problems and sterility issues. We now can use these large 4K monitors instead of the small little monitors that were being given that had poor resolution. We now have the ability with new technology to do more. I think that's going to change everything.
Yeah, and I think, if you look at the cost of Synergy versus the standard machines, I mean, it's almost 3 to 1, close to 4 to 1 for some machines. And so if you have 4 rooms and you have an ultrasound probe in every room already, you're going to be much quicker to use that versus having to come back out and bring the machine in a busy clinic. I mean, minutes and seconds count. So it's hard to try to get people to do things that are going to make them be inefficient, but this will really help that.
So Kevin, maybe you could describe your learning curve with ultrasound.
Yeah, so when I started in residency, we initially did a study early on looking at how quickly can residents and sports medicine fellows become accurate with ultrasound. And that was kind of my base when I started learning how to do this. And I actually did a meta-analysis on the use of ultrasound with orthopedic surgeons. And if you look across the board, most orthopedic surgeons, because our three-dimensional understanding of anatomy really is superior to every other specialty because we operate on these body parts. We look at MRIs, we look at x-rays, and no other subspecialty has that advantage that we do. So our understanding of anatomy is already very good. And then you take someone that already has arthroscopic skills, their ability to manipulate the probe and see what they need to see is also very high. And so most orthopedic surgeons, I think, are surprised at how quickly they can become adept at doing this. And I think almost all pre-op areas have ultrasounds in them now for blocks. And so just grab the probe and ultrasound your patient, even though you know they have a tear, and picture that tear in your mind's eye when you go in to scope it. And that is just a priceless learning opportunity that we as orthopedic surgeons have that radiologists don't have and other subspecialties don't have. So I think 50 to 100 scans and you're approaching 90% for full thickness rotator cuff tears in terms of sensitivity and specificity.
Gentlemen, what about your learning curve? Hey, Brian?
I found that really after taking a course, the best thing for me was actually going directly to the operating room. To truly get down the anatomy and to validate my ability to see things, we would use our intraoperative assessment and then verify it by arthroscopic techniques, a lot like how we probably would use MRI initially. So that's how I started, but we sort of evolved over time, especially as we've been using it for therapeutic injections, to doing it in the office. And I'd say my learning curve was sort of threefold. It was first doing a course, which I think is really important. I've repeated that course again, and then just really be a student and listen and practice, and then take it to the operating room. And now back in the clinic, the learning curve is actually flattened out. And I agree, it's probably in the neighborhood of 50 or more of certain joints for sure, where you're very, very comfortable. I found that tendon has actually been pretty easy. That's, you're looking in 1 or 2 planes, and that part has been easy from a therapeutic injection point of view. But any dynamic three-dimensional structure has been a little bit more challenging, and the operating room has helped me a bunch.
Mm-hmm. Alan?
I came back from Europe and I was very interested, so I got a machine and I started basically poring over anatomy books. I actually got MRIs of normal shoulder and knee joints and hip joints, and I started going through screen by screen, image by image on each cut, and I would basically correlate it with the anatomy books. I'd have my machine there and I'd be scanning different people. Eventually I actually brought it into my clinic and I started getting, normally as a surgeon would, MRIs of all my patients. And then whenever I got any kind of positive outcome, positive result with pathology, I would ask the patient to let me scan them to be able to correlate what I saw on the ultrasound with what I saw on the MRIs. And very quickly I could determine that I was actually very accurate and confident with what I was seeing.
Yeah.
You guys were obviously talking about orthopedic surgeons, but there's lots of people who use ultrasound. So maybe you guys could comment on that. Do you guys have any experience with dealing with other allied healthcare professionals using ultrasound and how long it took them to get up to speed?
The National Athletic Trainers Association has come out and talked about trainers being able to use ultrasound under the guidance of a physician and actually being able to diagnose using it. And so my trainers in all of my training rooms have ultrasound, they use it. Physical therapists likewise are able to do it. Now with their doctorate of PTs, they can do this as well and use it to diagnose. MAs, nurses, everyone can use these things, and it's an amazing utility that allows them to expand their ability to take care of patients.
We've used physician extenders for years in our practice. We have a sizable group, excess of 40 physicians, and I would say the average PA count is about 2 PAs per physician. And in fact, we've gotten to the point now where my physician assistants actually teach the course. They've become so facile at it. They still require our oversight, they still require our clinical input, but that being said, it is a task and it's something that you get better and better at, and you don't need to be a licensed physician to do it. So I think from my perspective, using our physician extenders has really extended my ability to manage patients, and they're very, very happy.
So gentlemen, any final thoughts? We'll start with you, Kevin.
I just want to say I think ultrasound's an incredible modality. I think that the new Synergy platform that Arthrex is developing is going to really bring it to the masses in terms of orthopedic surgeons. I think it's our job as some of the few orthopedic surgeons that know how to do this and have experience with it to kind of educate people, and I think Arthrex has done an amazing job of trying to find a way to help spread ultrasound to all the orthopedic surgeons that they work with to help them treat their patients better, because I know that's their mission, that's their goal, and I think it can do that. And I think it's this system, this platform, I think is really going to help this modality grow big time in the future.
I think this has really been evolutionary for our practice, and in some ways even revolutionary. You know, we still have to be good physicians, we have to take a history, we have to do a physical, and then you sort of move on to requisite tests. And an ultrasound has been a really efficient, accurate way for us to actually not only diagnose something, but actually treat it. And it's been efficient, cost effective, and the patient acceptance and engagement has been really high. So it's one of those things that I wish I had in the first 10 years of my practice, because I think it would have made a huge difference, and I think I probably would have done better in terms of my ability to make my patients better. We're just grateful that we have these opportunities now, and I think what Arthrex is bringing to the table in terms of continuing education, which is going to be a big part of this, and to enable to be portable, get rid of the wires, use it both in the office and the operating room, is really going to be a game changer compared to anything else that's out there. So we're looking forward to really integrating it at a high level in our practice.
I agree, it has been a complete game changer, but not just the ultrasound. I think with this new technology that we're being offered with Synergy, it's a game changer because it's wireless, it's got no cords. It's something that we can just put into a bag in the OR. We're not going to have a risk of contamination. We're not going to have to be now tethered to tiny little monitors that are far away from us. We now can use our Synergy towers with 4K monitors to be able to get better resolution. It's something that we can now use in conjunction with everything else. It's portable. We can now use it on the sidelines with tiny little iPhones and Android or iPads. This has absolutely changed what we're going to be able to do and how we treat patients. This technology is only going to get better with time.
Gentlemen, thank you once again for joining us today.
Thank you.
For more information on Arthrex Synergy MSK Ultrasound by Clarius, contact your local Arthrex representative. You can also visit and register at arthrex.com or at synergymskultrasound.com to learn more about how ultrasound can be used to help you treat your patients better.